بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. How are you everybody? I hope that all of you in good health. This lecture is presented to you by Dr. Nora Sabah from Kerbala Medical College. Our lecture today will be about abnormal uterine bleeding. The objectives of the lecture: first we will start with definition, then the types of abnormal uterine bleeding, what are the causes of abnormal uterine bleeding, and how we will assess patient with abnormal uterine bleeding, and then how we will manage her. So first, what we mean by abnormal uterine bleeding. It is defined as bleeding from uterine corpus that is abnormal in volume, regularity, and or timing that has been present for the majority of the last 6 months. The types of abnormal uterine bleeding. First of all, we have heavy menstrual bleeding, and this term is replaced the previous one, which is menorrhagia. What we mean by heavy menstrual bleeding? It is regular excessive menstrual blood loss over successive cycles that affect her quality of life. The second type of abnormal uterine bleeding is intermenstrual bleeding, and it replaced the previous term, which is metrorrhagia, which is an irregular bleeding between periods. Often those patients have either endometrial or cervical polyp, or sometimes patients with endometriosis also will have intermenstrual bleeding. These are examples of causes of intermenstrual bleeding. The third type is postcoital bleeding, which is bleeding that occurs after sex. Usually the causes are of cervical origin, but even if there is uterine causes, also they may affect the patient and cause her postcoital bleeding. For example, patients with PID. Postmenopausal bleeding, which is a bleeding that occurs after 1 year of cessation of periods, and it is abnormal. Bleeding of endometrial origin, which is a diagnosis of exclusion. Previously, it was termed as dysfunctional uterine bleeding, DUB, but it's replaced by this new term, bleeding of endometrial origin. We cannot say that this patient have bleeding of endometrial origin unless we exclude any pelvic pathology first, and we should ensure that the patient is not pregnant and have normal cervical smear. So when we exclude all the causes that may cause abnormal uterine bleeding, then the patient will say that she has a bleeding of endometrial origin. The pathophysiology of bleeding of endometrial origin. The cause of bleeding lies at the endometrium itself. There is either overexpression of prostaglandins or reduced level of vasoconstrictor endothelin and increase in plasminogen that cause premature clot lysis. It may be also there is maybe an imbalance in the hypothalamo-pituitary ovarian axis that lead to this bleeding. What are the causes or the classification of abnormal uterine bleeding? And also we can say it about heavy menstrual bleeding. In this picture, these are the common causes of heavy menstrual bleeding, and they are classified, the causes, generally into structural and non-structural causes. Structural causes may be fibroid, adenomyosis, endometrial polyp, endometrial, or cervical carcinoma. Maybe even benign endometrial hyperplasia also may cause heavy menstrual bleeding or abnormal uterine bleeding. The non-structural causes of abnormal uterine bleeding are either coagulation disorder, or if there is ovulatory dysfunction in this female, pelvic inflammatory disease, thyroid disease, drugs, which is an iatrogenic cause of abnormal uterine bleeding. The presence of intrauterine device also may be a cause of abnormal uterine bleeding, or if there is endometrial dysfunction, which is the bleeding, which may cause heavy bleeding to this patient or abnormal bleeding. How we will assess the patient who presented with abnormal uterine bleeding or even with heavy menstrual bleeding? The same will be done for all patients with abnormal uterine bleeding. First of all, we should start with history. We should take the age of the female, the age of menarche, the menstrual pattern of her, whether the patient have regular cycle or not, and we should know the frequency of her cycle, whether the patient have polymenorrhea or oligomenorrhea, and the severity of the bleeding. The assessment of severity of a bleeding can be done by history when ask the patient about the number of pads that she used every day, the amount of the bleeding, the volume, if there is clots, or if there's flooding of the blood over her thighs or clothes or her beds, and if the patient become anemic because of this heavy bleeding, easy fatigability. Sometimes patient even may have a syncopal attack, the need of blood transfusion. All of these questions should be asked to the patient to know, to try to assess the severity of her bleeding. If she has pain during the mens, which is dysmenorrhea, or she has chronic pelvic pain, for example. The medical history is very important to ask about her, if she has hypertension, diabetic, any other disease. Surgical history also important, use of medication, because as we say that it is an iatrogenic cause of abnormal uterine bleeding or heavy menstrual bleeding. And the symptoms or signs of hematological disease, especially in those patients who are teenage, because maybe she has disorder, for example, coagulation disorder, that may be a cause of her abnormal uterine bleeding. On examination, first we start with general examination. The vital signs of the patient should be assessed. If there is any signs of anemia, signs of thyroid disorder, abdominal examination should be done then to the patient. If she has abdominal mass, whatever signs or scars of previous operations, complete abdominal examination should be done, and then pelvic examination. Start by inspection and then speculum examination to exclude there is any signs of infection or cervical polyp, for example, cervical ectropion, whatever. If there is any abnormality, pap smear, if the patient is not up to date in hair smear, we should do for her, and then we should do bimanual examination for the uterus and the adnexia. After that, we should send the patient for investigations. The important investigations that should be sent to the patient, some of them are routine, that should be done for all of them, and others are indicated according to her history or the findings that we found in her examination. So all of those patients should be sent for full blood count, because as we say that she may have anemia, and this may will presented by her full blood count. Any patient in the protective age group who presented with abnormal uterine bleeding should be sent for pregnancy test to exclude pregnancy. Even if she said that she is on contraception, we should exclude that. It is important, and I hope that you will not forget this information. Cervical smear, as we say, if she's not up to date, we should do it. Thyroid function test and coagulation screen. It is not routine, but if the patient has symptoms or signs of hematological disease, or if she has signs of thyroid problem by examination, so we send the patient for them. Transvaginal ultrasound is very important because we will assess the pelvis, pelvic organ, the uterus, endometrial thickness, if there is any pathology, fibroid, adenomyosis, whatever, polyp, and if there is any ovarian mass. Then endometrial biopsy should be sent if the patient have increment in her endometrial thickness, or if she does not respond to treatment. So we should exclude any problem in the endometrium. Hysterectomy, it is an important method for investigating the uterus. We can see the uterus directly. If there's any pathology, polyps, mucosal fibroid, there's endometrial hyperplasia, whatever. And also we can take biopsy, which is hysteroscopic guided biopsy. And if there is any pathology also, we can remove it. So it will be a diagnostic and a therapeutic method. How will we manage patient with heavy menstrual bleeding? When we do investigation to the patient, if the patient has structural causes, our management will depend about the cause. If she has fibroid, we should treat fibroid, endometrial polyp. If she has thyroid problem, if the patient have coagulation disorder, so we will direct our treatment according to the cause. But if the patient just have heavy cycle without any cause, after exclusion of these causes that we said in the previous slide, and the patient categorized as a case of a bleeding of endometrial origin, or she just have heavy menstrual period, which is regular, and there is no pathology behind it, so we can use these methods, these lines of treatment. We have medical and surgical lines of treatment. First of all, we will start with the medical treatment, and the first line of medical treatment according to the newest guideline is we start with Mirena, which is the intrauterine contraceptive device that is loaded with progesterone. As you know, the Mirena is one of the contraceptive methods. So when we want to use it to the patient, first of all, we should counsel her that if we put a Mirena to her, so she will not be pregnant during that time. And also we should ensure that the patient don't have any contraindication for the usage of Mirena. It is a very useful medication, and it decreases the menstrual blood flow for about 90%. Those patients will have endometrial atrophy. This is the mechanism of action of Mirena. And some patients will have even amenorrhea because of its use. This is the Mirena. It's come in the package with the inserter, and here the tube is loaded with Mirena, and this is after we insert it to the uterus. The second line of treatment that should be used to the patient is usage of antifibrinolytic, the tranexamic acid, and non-steroidal anti-inflammatory drugs. Both of them decrease nearly 40 to 50% of menstrual blood flow. So it is a good line of treatment, especially in patients who have acute bleeding. But also we should ask the patient if they don't have any contraindication to this medication. For example, regarding antifibrinolytics, we should ensure that the patient have no history of previous thromboembolic phenomena. Combined pills also decrease the menstrual blood flow, and it regulates the cycle, and it's one of the options, but also we should know that the patient don't have any contraindication for its use. And when we use it also, we should tell the patient that it is a method of contraception. which is very important. The third line of treatment is the oral progesterone, especially if the cycle is irregular. It decreases menstrual blood flow by about 30%. We use it at least for 21 days, from day 6 to 26th day of cycle. It's used 3 times per day, so the dose will be 15 milligram. Each tablet is 5 milligram, and we can use it continuously for 3 months. What I mean by that the patient will take it every month without any withdrawal bleeding, yani not for 21 days, but for 3 months continuously. This will help the patient to build up her iron stores and to stop bleeding, especially those patients who have psychological side effect because of her irregular bleeding. And this is use of progesterone stem back to back, which means that we use it month after the other without any withdrawal bleeding. It should be used for 3 months and then discontinue the drug, so there will be a withdrawal bleeding. GnRH agonist, it is one of the medication that produce amenorrhea, because it will stop the release of LH and FSH from the pituitary gland, so the patient will not have any ovarian cycle, and she will be amenorrheic in 100%, and those patients don't have any bleeding during the usage of this medicine. But there is some precautions in its use. We cannot use it for more than 6 months, because those patients who use it will have menopausal side effect, which is hot flashes, nightmare, sweating, and osteoporosis, and etc. So it will be in a pseudomenopausal state. So if we want to continue its use for more than 6 months, we can use it with its hormone replacement therapy, HRT. It comes in form of injection. This is one of its example. The Zoridex, GnRH agonist. It comes this injection, and the patient take it monthly. It's also of benefit in patients with fibroid, with patients with adenomyosis, because it will have effect and decrease the size of the uterus, decrease the size of fibroid and adenomyosis, and the patient will have no bleeding. For patients who have large fibroid, we can use it before surgery, so it will decrease the size of fibroid, so we can even change the route of operation, for example, from laparotomy to laparoscopy, from transabdominal to transvaginal if the patient wants to do hysterectomy. The surgical method of treatment of patient with endometrial, with abnormal uterine bleeding, we can use with hysteroscopy. Hysteroscopic guided endometrial ablation, which is widely used nowadays, but in this method of treatment, we should tell the patient that what we will do is we will burn all the layers of the endometrium, even the basalis layer, so the patient will not have endometrium, which is healthy, so she cannot get pregnant after that. And what we will do is we will induce Sherman syndrome. So those patients who want or who agree about this method of treatment, we should tell them that they should not get pregnant, and she should complete her family before we use it. There is complication of this method. There will be infection, perforation, for example, bleeding, and in some patients they may have recurrence of the uterine bleeding. Hysterectomy, it is the last line of treatment in those patients, and they will be cured 100%, because we will remove the source of bleeding. We should not use it for young women, and it's mainly used to patients who are in the perimenopausal age, and they should complete her family. We have two types or many types of hysterectomies. The commonest one when it is the total hysterectomy or partial hysterectomy. The total hysterectomy when we remove the whole corpus with the cervix, and the partial hysterectomy when we remove the uterus, uterine corpus just and preserve the cervix. Now, how we will manage a patient who came to the emergency unit with acute heavy menstrual bleeding. It is an important and common cases that you may see in the emergency room. Sometimes those patients, either it is the first presentation to them or it occurs with a chronic history of abnormal bleeding or heavy menstrual bleeding. What we will do to those patients, first of all, we should admit them to the hospital. We do take history from her and complete examination. Vital signs, abdominal, pelvic examination should be done. We send her for investigation. The full blood count, coagulopathy, we should exclude the pregnancy from those patients, and then we should try to replace what she lost from her blood volume. We start with fluid, and if she needs blood transfusion, we can transfuse her blood. The medications that she use, either we give her tranexamic acid, either orally or IV, and it will help her to decrease the amount of bleeding. If there is ultrasound at time of examination, we should send her for pelvic ultrasound when the patient becomes stable to know the cause of her bleeding. The other medicine that we use here in the emergency unit, we can give her high dose of progesterone to arrest the bleeding, or heavy dose of combined pills. And there's a regime for the use of combined pills. What I mean by heavy dose, we start with 4 tablets, then 3 tablets, 2 tablets, and then she continue on 1 tablet. Then if the patient becomes stable and we diagnose her as a case of bleeding of endometrial origin, we can discharge the patient on GnRH agonist or allopurinol acetate, which is a selective progesterone receptive modulator, and it can help her stop her bleeding. And the long-term plan will be discussed with the patient, and it will depend about her diagnosis. So, at the end of the lecture, I want all of you to remember these important notes. In teenage girls who presented with heavy menstrual bleeding or abnormal uterine bleeding, as I say, you should put in mind coagulopathy as a cause. Thyroid diseases also can cause severe abnormal uterine bleeding. Do not forget to check for foreign bodies in young girls, because it may be the cause of hair bleeding. We should exclude the pregnancy in reproductive age group women with abnormal uterine bleeding. And thank you.